And now the presentation. Okay. Now the presentation is by Professor Ruben Alvaro for post-operative care of CDH from operating room to home. Thank you very much, and it is very nice to meet you and Yasser after COVID, to meet you physically. Thank you very much indeed.
Good.
Okay, the floor is yours.
Thank you for, again, for the invitation to present today. So what I'm going to do now, I'm going to try to convince you that having a protocol for management of diaphragmatic hernia in your unit is a major step to improve mortality and decrease morbidity. It's like giving you a recipe, but the recipe is just to how to initiate the management of these babies prenatally, at the time of delivery, and after surgery. It's been shown that units that have developed strict protocols in management are the ones that actually have better outcomes. So don't leave it up to the person on call to decide what to do. If you don't have a protocol in your unit to manage infant with diaphragmatic hernia, you should develop one. Having said that, these protocols are supposed to be followed, but also supposed to be changed according to the response that the patient, the infant, develop according to the treatment that you're implementing. Okay? So I'm going to try to give you those strict protocols that were developed by the American, the Canadian, and the European diaphragmatic consensus. So this isn't just me. There are a group of people that are following these babies that have been proven with that these protocols, you can actually improve mortality and decrease morbidity. So I have no conflict of interest to declare. As you know, diaphragmatic hernia is a very complex condition, and the defect that develop in the diaphragm in the first trimester allow bowel content to go from the abdominal cavity into the chest cavity. And when that happens, then the lung on that side of the defect will be significantly compressed and will not allow to develop properly. And if the defect is large and the amount of bowel that you ended up in the chest is significant, that may actually cause mediastinal shift and can also compromise the development of the other lung on the other side. And those are the cases that end up to be more severe. So we know that diaphragmatic hernia has an incidence of about 1 every 3,000 deliveries. Depends where the location that you're training. It could be from 2,000 to about 5,000. As I said before, because of the amount of bowel in the chest compress the lungs, these lungs are not allowed to develop properly, and you end up with a significant pulmonary hypoplasia and pulmonary hypertension that will determine the mortality and the morbidity in these cases. And as Yasser said, it requires an integrated multidisciplinary care across 3 distinct phases: prenatal, perinatal, postnatal, and also in follow-up childhood and adolescent. So this is not just a problem at birth. This is a lifelong defect that will impact the baby's life. So if you were to classify the type of diaphragmatic hernia, you can do it by location. Most of the diaphragmatic hernias occur in the posterolateral area of the diaphragm. Most of them occur in the left. About 85% of diaphragmatic hernias are present on the left, and only 15% on the right. About 70% of the diaphragmatic hernias are posterolateral, about 25% are anterior, and about 5% is central. The ones that are associated with central, bilateral, or right diaphragmatic hernia are the most severe ones, and the ones associated with more severe outcome. So, there is a few conditions that can mimic diaphragmatic hernia, and we need to be aware of that, although we are getting better and better on how to diagnose these conditions prenatally. One of those conditions is CPAP, or congenital pulmonary adenopathic malformation. It used to be called CCAM. Now most people will refer as CPAM. And it's basically a benign lesion in which a part of the lung is not properly formed and develop a mass or a cyst, and does have normal function, but it causes a mass effect, similar to the bowel effect in the chest. Now, this condition, as you can see here, can sometimes mimic, especially postnatally, the bowels that you see in diaphragmatic hernia. The main difference is in this CPAM, you can see the edge of the diaphragm on that side completely. In diaphragmatic hernia, you tend to lose that shape of the diaphragm on that side. Okay? Now, the CPAM usually is benign. In most cases, the mass will expand to about 28 weeks gestational age in utero, and then will stop growing. And as the lungs get bigger and bigger and bigger with gestation, this mass will get relatively smaller and smaller and smaller, and most babies will not need any treatment after delivery. There are a few cases in which the CCAM will remain, will keep growing, and may cause significant lung development and pulmonary hypertension. And those are the cases that are also difficult to treat. But hopefully most of them they do well. Other conditions that can mimic somehow diaphragmatic hernias are diaphragmatic eventration, bronchopulmonary sequestration, bronchogenic cyst, bronchial atresia, teratomas, and finally a pneumothorax. Again, nowadays with the very good prenatal ultrasound that are following these babies, very, very few times we can confuse diaphragmatic hernia with any of these conditions. So the pathophysiology of diaphragmatic hernia, I think Yasser explained that very well. Basically, you can summarize it as pulmonary hypoplasia of the ipsilateral lung, or the lung that has the defect. And that's because you don't allow the lung on that side to remain slightly open. Remember that for proper lung development, you need to maintain some degree of lung alveolar expansion that will promote alveolar growth and capillary growth. When you have a mass effect that is compressing that lung, you're not allowing that fluid to remain inside the lungs, and then the lung loses volume. And that causes arrest, alveolar and vascular development, and also causes pulmonary vascular remodeling, which is called fixed pulmonary hypertension. You also have another type. There are two types of pulmonary hypertension. One is what we call fixed pulmonary hypertension. It's the one that you can't really change with treatment, and that's because the cross-sectional area of those vessels is significantly decreased, and you can't grow vessels out of nothing. And also because you have an extension of the smooth muscle into the most terminal capillaries inside the lungs. Again, that remodeling, as far as we know right now, we cannot change that after birth. So that's what we call fixed pulmonary hypertension, and that's not going to be respond to any medications or nitric oxide. But there is another component of pulmonary hypertension that is called vasoreactivity, that is usually associated with an imbalance of vasoconstrictors and vasodilators present in utero. The most important vasoconstrictors are thromboxane and endothelins. The most potent vasodilators are nitric oxide and prostacyclin. Okay? So there is an imbalance usually between vasoconstrictors and vasodilators. Those are the ones that you can modify with your treatment after delivery. And also, this is not just a problem with the lungs. Even in the absence of congenital heart disease, many of these babies will have an abnormal cardiac function, especially on the left ventricle. And those are the tough cases, because when you have a left ventricle that is not functioning well, you're going to have increased left atrial pressure, and that's going to cause venous pulmonary hypertension. And that's very, very difficult to treat. Okay? So all these babies will have an assessment, as Yasser said, right after delivery, to assess not only the lungs, but also the cardiac function. So, antenatal management and prognostication. Well, first of all, there are few things that we can look prenatally to decide if the diaphragmatic hernia is going to have a poor prognosis or a good prognosis. None of these elements are going to be 100% sensitive or sensitive. So we know that the presence of the liver inside the defect is associated with a very poor prognosis. Okay? So prenatally, you want to know where the liver is. If the liver is in the abdomen, that's a good news, that's a good sign. If the liver is inside the chest, that's unfortunately a bad sign, and it's usually associated with very poor survival. Also, we know that if you have an isolated diaphragmatic hernia, the mortality is only 10 to 15%. However, when you add one extra congenital defect, the survival can go down to maybe 40 or 50%. So the presence of another congenital anomaly will significantly increase the mortality and poor outcome. Now, there is another measurement that prenatally most of our fetal assessment obstetrician can do, and it's looking at the expected lung-to-head ratio. And this expected lung-to-head ratio has been associated with different percentage of survival or mortality. Okay? So you basically compare what's normal for any gestational age, and you compare with your case. So we know about studies done with expected lung-to-head ratio that if your ratio is less than 20%, you only have about 30% survival. If your ratio is 26 to 35%, you have better lungs in relationship to your head, the survival increases to 62%. If the ratio is between 36 and 45%, survival goes up to 75%. And if you have more than 45% ratio, lung and head, the survival usually is about 85 to 90%. So not 100%, but very, very high. If you anticipate that the birth will occur before 35 weeks, prenatal steroids are indicated and it should be given. However, there is no evidence that if you're going to deliver this baby after 36, 37 weeks, that prenatal steroids should be indicated. So right now, there is no indication to give prenatal steroids if your baby is going to be born at term. So, what else can we do antenatally? It's extremely, extremely important to involve the parents as soon as you make diagnosis of diaphragmatic hernia. Why? Because first of all, you need to educate the parents. Most parents don't have any clue what a congenital diaphragmatic hernia is, and they don't have any clue about the severity and the complexity of this condition. So informing them prenatally of what to expect is going to be extremely, extremely important. Okay? And also they can prepare themselves to be in the unit. They may want to visit the unit. They want to get familiar with where the baby is going to be. And you can discuss with them what's going to happen after delivery in terms of management, what's going to happen to their babies, if my baby's going to cry, I'm going to hear the baby cry or not, and things like that. So for the parents, it's extremely important to know beforehand what's going to happen to the baby. It's important that as soon as you make diagnosis, you refer the case to a pediatric cardiologist prenatally. Okay? Usually in our center, our cardiologists do a fetal echo around 22 weeks to rule out any other congenital heart disease. Genetic consult is also important because many of these cases are associated with other genetics conditions. So possibility of doing an amniocentesis should be provided to the parents for microarray. It's also important, I think we have one pediatric surgeon here. I don't know where he is. There you are. Yeah, there you are. So it's important to refer these patients prenatally. Not because they're going to do anything prenatally. It's because they may want to sit down with the parents, explain to them what to expect, and prepare the service for a case that usually are very complicated and difficult to treat. Routinely, prenatal ultrasound surveillance is the standard of care. Usually these babies are being followed every 2 to 3 weeks by serial ultrasounds to see how the baby is developing. And if there is any other signs that will also predispose to a bad outcome. We know that polyhydramnios is also associated with a worsened outcome, and significant mediastinal shift is also associated with poor outcome. Those are the things that you can find out by doing serial ultrasound and see how how the patient is progressing. And finally, as I said, this is not a case for us. When you have a diagnosis of congenital diaphragmatic hernia, this will involve obstetricians, will involve pediatric surgeons, will involve the cardiologists, will involve the neonatologists, will involve the parents, and respiratory therapies and so on. So this is the only way you can get a good outcome out of these cases is having a multidisciplinary team, and everybody will contribute with their expertise. So being more practical now, I'm trying to be as practical as I can. How do we anticipate the delivery of a baby with diaphragmatic hernia? First of all, you need to get together with your team. You need to discuss what you're going to do. You need to discuss who is going to do what. Okay? The nurses, I guess, you need to have the most senior nurses with the most experience present at the delivery. Okay? And you're going to need more likely 2 to 3 nurses. Okay? You need, if you have RTs in Egypt, I don't know if you have RTs, in North America we do, you need to talk to them, be sure that they're ready. They may have to have a conventional ventilator and also maybe a backup high frequency ventilator in case conventional ventilator fails. And you need to discuss the settings that you're going to start the baby with and what the role of the respiratory therapist will be. You need to have a second physician or a third physician. It could be a fellow or a resident. And also you need to have the most senior neonatologist present at the time of delivery. So again, discuss with your team what everybody is going to be responsible for at the time of delivery. Because you don't have to start guessing who's going to do what. Who's going to intubate, who's going to put lines, who's going to put an IV, who's going to record, document everything that's going on, and so on. So the more prepared you are, the better the outcome. So, team huddle to discuss plan of care and define team members' roles. Also, you need to have all the supplies ready. You can't just start looking for a double lumen UVC or an R-line. Where is it and where's the tube? And you have to have everything ready, okay? You have to look for the endotracheal tubes, the right size, vascular access, laryngoscope, everything that you need to treat a very complex case, okay? So you cannot improvise, because improvisation is not associated with good outcome. Also, you need to plan how you're going to transport this baby from the resus to your unit. Now, I don't know how far your unit is from the delivery room. In some cases, it's right there. Some cases, like in ours, is we have one floor, the resus is one floor above the NICU. So we need to be sure that we have everything in place to be able to transfer this baby safely to your unit. And that needs to be discussed. So, going more now into practical aspect of what to do with the baby at the time of delivery. So there are a few immediate goals that need to achieve when a baby with diaphragmatic hernia is born. The first one is to avoid using high airway pressures, okay? So this baby already has abnormal lungs, and we know that. The worst thing you can do is superimpose acute lung injury to that lung that is already maldeveloped, okay? So avoiding high pressure is crucial. Second, you need to, and this is what Yasser referred to, you need to establish adequate perfusion and oxygenation as soon as the baby is born, as soon as you can. You have to have a plan for that. Maintain normal perfusion, blood pressure in normal range for the gestational age. That's also the immediate goal. So, how are you going to monitor this baby? What are the things that you need to monitor in a baby with diaphragmatic hernia as soon as the baby is born? These are just basic stuff. You need to monitor heart rate. You need to measure pre- and post-dactyl SATs, okay? Ideally, your aim should be pre-dactyl SATs, but you need to be aware of the difference between the pre- and the post-dactyls. So you need to have 2 oximeters. Ideally, you want to monitor the blood pressure continuously. So you have to have an arterial line, either pre-dactyl or a UAC. You need to do frequent arterial blood gases, especially in the first few hours of life, because you're going to have to change your management quite a bit, okay? These babies change a lot. The lungs will change a lot. The hemodynamics will change a lot, even in short period of time. So you need to be ready to do frequent blood gases. Also, these babies, as soon as you intubate, you need to do a chest X-ray. You need to do a chest X-ray to know if your endotracheal tube is in the right position and it's not in the right or the left. You need to do a chest X-ray to know if the NG that you put is actually going into the stomach and is decompressing the bowel. And if you have put lines, you need to know exactly where those lines are. If you have the ability to do NIRS, definitely that will help. But I'm aware that not everybody has the ability to do NIRS, especially in the delivery room. But that would be an added important monitor that you can add. And also, as I said before, this doesn't have to be done in the recess, but it's important that you do an echo as soon as the baby is admitted to the unit. For anatomical purposes, usually we ask our pediatric cardiologist to do the first echo. But in many cases, if they are not available or the baby is born in the middle of the night and you have a person in-house that can do TN echo, will allow that person at least to have a look at the heart and see if there's something normal. And it will give us also a good idea of how the left ventricle and the right ventricle are functioning. And measure also the degree of pulmonary hypertension. So, what are the things that we need to do immediately at the time of delivery? Now, first of all, delayed cord clamping is not recommended at the present time. Okay? Now, this may change. But right now, the standard of care is that you do not wait for delayed cord clamping. You should clamp the cord right away. Now, having said that, we know that physiologically it makes a lot more sense to at least wait until the baby takes the first few breaths before you cut the cord. Okay? But not do a 1 minute delay cord clamping. That's not presently indicated. Terminal relationship, well, that's easy. These babies can get cold quite quickly, and on top of the complexity of the diaphragmatic hernia, if these babies get cold, you're going to get into trouble with management. So you need to be sure that these babies maintain normal temperature throughout the stay in recess. One of the first things you do is place an oral or nasogastric tube with continuous intermittent suction and keep the baby NPO until the time of surgery. This is, again, considered standard. And the main reason for that is because you need to decompress the bowel as soon as possible. Central venous access is extremely important because you need to infuse many times more than 1, 2, or 3 different types of infusion. You need to have a secure central line access for maybe inotropes, fluids, and other medication that we may need to use, especially sedation. So UVC usually is placed in the delivery room. As I said before, you need to have an arterial line, either UAC, but ideally you want to have a radial preductal line that can give you a better information about preductal gases. In terms of IV fluids, the only thing these babies need right away in the recess is dextrose and water. You can wait for the TPN when the baby gets to the unit. And these babies tend to develop third spacing quite quickly. So you need to be careful with the amount of fluid you give. Okay? So usually we recommend to do fluid restriction, definitely no more than 65 per kilo per day, and then you adjust your fluids according to the urine output and the perfusion and so on. But these babies will all have third spacing and will retain fluid. So you need to be careful how much fluid you give. Okay? Now, let's go to intubation and ventilation. What do you do first? Do you paralyze these babies? You intubate them right away? You let them breathe? Is this an extreme emergency that you have to have a tube in? What do you think? Because we used to do that. About 20, 25 years ago, the first thing, the priority was, don't let the baby breathe. Put the tube in as soon as possible. That recommendation is not accurate anymore. Definitely these babies need to be intubated, but it's not going to hurt the baby to take a few breaths on their own. Okay? And right now, unless the condition is not manageable and is a case of severe diaphragmatic hernia, we usually allow these babies to breathe spontaneously. Okay? As long as you can decompress the tummy well with your tube, there is no need to keep these babies paralyzed all the time. Okay? And if you're going to use paralysis, what I usually tell the nurses is to maintain light paralysis, which means that you don't routinely give the medication every 2 hours. You wait until the baby wakes up, start breathing, and you only give paralysis if you cannot control ventilation, oxygenation when the baby starts breathing. Okay? It's been shown that if you paralyze all these babies, the outcome usually is worse than if you let these babies breathe on and off on the ventilator. Okay? So, one thing you need to avoid is bag and mask. Okay? Most of these babies do not need bag and mask. Most of these babies are born, especially if they had a good prenatal management, these babies are usually born in good shape. Okay? They usually breathe right away, and they don't get into trouble. They don't develop severe asphyxia. So they don't need bag and mask ventilation, and you need to avoid that, for sure. Immediate intubation, yes, but again, it's not an emergency. It's not like you have to intubate the baby at the perineum, or if it's a C-section, right on top of the mouth. You can take the baby to the resus room and if you can do medication for intubation, before medication, you need to do that too, okay? So intubation is important, but it doesn't have to be done extremely fast. You can take your time. Gentle ventilation, as I said before, is crucial. You need to use the minimal amount of pressure to open up the lungs, okay? These lungs are precious, and these lungs you know already malformed, especially the one on that side of the defect. So you need to protect whatever lung is left on that side, and also protect the good lung. And remember, the good lung is going to do all the work, or most of the work, okay? So, and usually the good lung will have to do the work of both lungs. So you need to protect that lung as much as you can. So how do we do gentle ventilation? By usually avoiding peak inspiratory pressure more than 25 millimeter mercury. So that's usually the top. And if you cannot ventilate, oxygenate, using pressure up 25, you may need to switch the ventilatory mode from conventional to high frequency. In the first 2 hours, you do not need to aim for normal blood gases, okay? So you can aim for what we call permissive hypoxemia and permissive hypercarbia. It's usually recommended in the first few hours, as long as your postductal saturation is over 70%, and your preductal is about 85%, you're okay. You don't need to hammer the lungs or give 100% oxygen to aim for 90%. That's not necessary, okay? Most of these babies will be stable enough if you try to maintain those limits. And again, you don't need to aim for a CO2 of 40. You're dealing with one lung. So even if PCO2 in the 50s or high 50s is more than enough, okay? So you have to be patient. You can't just hammer these lungs to try to obtain normal blood gas, because you won't be able to unless you damage the lungs, okay? And again, aim for postductal sats about 70%, and usually that's good enough. The mode of ventilation that we use, again, there is no evidence that using prophylactic high frequency will improve your outcome, okay? Actually, there was one study that compared both modes of ventilations in babies with diaphragmatic hernia, and showed that babies that were kept on conventional ventilator did better, okay? So, again, we try not to leave this option to the attending physician or the attending neonatologist on call. Ideally, you want to have a guideline that said every baby will be at least tried on conventional ventilator, okay? So, if you ask me, and this is what we're going to propose in our unit, is AC-VG as the initial mode of mechanical ventilation. But you need to be ready to switch. If using AC-VG you cannot obtain reasonable blood gases and your PIP is exceeding 25, you may need to try a different mode of ventilation to see if you can obtain better ventilation and oxygenation using a less invasive mode of ventilation. In our center we use the jet, but using the oscillator is a good option too. In general, surfactant is not indicated, okay? So surfactant is not considered standard of care in babies with diaphragmatic hernia. Most of the studies have shown that surfactant does not significantly improve outcome. Now, having said that, there are a few cases in which if you cannot improve the compliance, you may want to try maybe a dose surfactant and see if you can get a response, but it's not routinely indicated. So I'm going to give you, again, these are just guidelines on where to start, okay, if you're on conventional or high frequency oscillator or the jet. But again, These are just guidelines, and you need to be ready to change those settings according to the response you get from the baby, okay? Don't think that these are the only numbers that you can use. So, if you are using conventional ventilation, again, use always AC-VG mode. The rate should be high, 60 breaths per minute. VT, about 4 per kilo. Now, remember, that 4 per kilo is not going to be distributed in both lungs. It's going to go to one lung only, okay? But unfortunately, it's very difficult to try to achieve normal ventilation with a volume of less than 4 per kilo. Because the amount of CO2 the baby is going to produce is going to be the same if he had 2 lungs. But unfortunately, he's only dealing with 1 lung or 1.5 or 1 1/4. So I don't think you can get away with less than 4 per kilo, okay? But again, that's why in many cases, the PIPs are going to be high, because all that volume is going to go basically to 1 lung, okay? So it's basically, in a normal situation, if you have 2 lungs, it's like using 7 or 8 per kilo, which is high. Use adequate PEEP to maintain lung open. This is what I discussed before. I can't give you a number. Usually you start with low numbers, 5, and then adjust that PEEP according to the FiO2, the chest X-ray, use lung ultrasound, whatever you use, and you should recruit the lungs to be able to expand whatever lung you have there, okay? Inspiratory time, again, most of these conditions, diaphragmatic hernia is a condition that we assume that is non-homogeneous lung disease, so there is a risk for trapping, okay? But again, remember that the time constant, which is what's going to determine the risk for trapping, is compliance times airway resistance. So most cases of congenital diaphragmatic hernia, the airway resistance is not that high. It's not like meconium aspiration. And the compliance, it could be low or it could be normal, okay? So if you have normal resistance and normal compliance, the time constant is going to be low. It's going to be short. So you can use higher rates. You can use shorter TIs. You can use short TEs. But in general, you need to be aware that many of these babies will have a longer time constant, and they're going to be at risk for air trapping, okay? So I would say start with 0.35, and then you may need to adjust, look at your flow waveform, and see if you have enough time there to achieve proper lung inflation. If you decide to switch to high-frequency oscillator, I recommend that using low frequencies, again, for the same reason, because of the potential risk for air trapping, usually no more than 5 to 7 hertz. Mean air pressure, I can't give you a number, but if you switch from conventional to the oscillator, even if you were happy with your mean air pressure on the conventional, to achieve the mean air pressure on the high frequency, you need to use 2 centimeters of water higher to achieve the same lung expansion, okay? Because of the effect of sucking the air out of the lungs on the high frequency oscillator. So when you switch, try to aim for 2 centimeters of water higher of mean air pressure than what you had in the conventional. Amplitude, again, enough amplitude to control CO2, but never more than 3 times the mean air pressure because of the risk of air trapping. If you use the jet, again, low frequencies, 240. Adequate PEEP to maintain line volume, usually 2 centimeters higher than conventional mechanical ventilation to mimic the same mean air pressure, and adequate PIP to control PCO2. Because of the risk of trapping, we try not to use side breath on the jet, okay? Now, in general, sedation, analgesia, paralysis. I already talked about paralysis. I would not recommend doing paralysis unless you're against the wall and you can't oxygenate, you can't ventilate, the baby's fighting, you can't control the baby with sedation. You should use paralysis, but only light paralysis. Let the baby breathe and show you exactly that he needs that paralysis. So in general, we use pre-medication before intubation if you have the time and if possible. Try to maintain spontaneous breathing. That's going to help you with your ventilation. That's going to help you with your hemodynamics too. If you use sedation, usually we pick morphine or fentanyl, whatever you are more comfortable with. Both of them are similar. Start with low dose. There's no reason to start with a higher dose. Most of these babies respond, especially at the beginning, with low dose morphine, 0.01 per kilo, fentanyl the same, 1 mic per kilo, and then you titrate up if needed, okay? And avoid boluses. Try to control the sedation with continuous infusion without giving boluses. As I said before, selective neuromuscular blockade in those with greater ventilation or oxygen requirement. And again, to minimize irritability, use minimal handling, cocooning, swaddling as soon as possible. Okay? Hemodynamic support, I think Yasser already addressed that. Look for signs of poor cardiac output and tissue perfusion. Look at the capillary refill. Look at the urine output. Look at the lactate. And that will say if you need to give fluids or inotropes and so on. Okay? And again, look at the normal values for blood pressure according to the age. If you're going to use fluid because you think the baby is hypovolemic, be careful with the fluids and only use crystalloid, especially at the beginning. Okay? And don't give more than 10-20 per kilo. If the baby is not responding 20 per kilo, most likely you're dealing with other type of condition that is giving you a low blood pressure. Okay? So remember, these babies are very high risk for developing third spacing and retain fluid. So you don't want to give too much fluid right away. Okay? Selection of inotropes should be based on T and echo, either hypovolemia, left versus right ventricular dysfunction, pulmonary hypertension, etc. As already Yasser addressed that. And consider hydrocortisone, especially if you have trouble with blood pressure, because many of these babies have a relatively adrenal insufficiency, and hydrocortisone have been shown to stabilize blood pressure in many of these babies. So I think that will end the first part of my presentation. So we'll leave the question for the end. And okay, the second presentation will be shorter.
Well, thank you, Professor Alvaro, Professor Yasser, for such a comprehensive look on the immediate management and perioperative management of the CDH. Well, I'll tell you my side of the coin, my side of the story. I mean, despite being a pediatric urologist, I've been always intrigued as a pediatric surgeon in training by CDH. I come from the days where the standard policy at that time was alkalinization, aggressive ventilation, and the people were starting to comprehend that it is not a surgical emergency, but rather a pathophysiologic emergency. And then our eyes were a little bit opened by the seminal work of Wang, and then thereafter by the CDH group and the Tale of Two Cities of Boston and Toronto. And we started to shift gears towards a more gentle, not even gentle ventilation, which I thank you so much for stressing this point, but even gentle overall management, a gentle holistic management for these kids. Probably the surgical exercise, although it has its hurdles, it is still, it's 1%, I think, of a fraction of the 99% work and the heavy lifting that is done by the neonatologists and the cardiologists in this regard. And basically, I mean, I just wanted to ask one thing. How do you interact with your team of pediatric surgeons and anesthesiologists as well? And who decides when to operate? Because every time I ask this question to an eminent neonatologist or a surgeon, things just get a little bit fuzzy, or every place has its own rules. So what do you do in your center, both of you?
I want to believe that we have a good report with our pediatric cardiologists. So most of them will discuss these cases with us. Again, this is multidisciplinary. It's not we make the unilateral decision when to send this baby for surgery, nor the pediatric surgeon. Usually it's a combined decision between the neonatologist, the pediatric surgeon, and sometimes we get a second opinion from another neonatologist in the unit, a more senior person or whoever is on call in the other unit. So we discuss, and then we decide what would be the best time to do it. So, yeah.
So what's your comfort level in, I mean, at what parameters would you think that you're comfortable to send this patient to OR?
Yeah, I don't think I can give you a clear answer for that, because it will depend the severity of the pathophysiology you're dealing with. As Yasser alluded, if you have a case of mild pulmonary hypertension, there is on 25-30% oxygen, not on inotropes, there is not much reason to wait too long. Second day of life, third day of life, you can send the baby for surgery. If you have a more severe case in which the baby needs more inotropic support, very high ventilatory management, sometimes you have to wait. So that's why I can't give you one simple answer. But we look at the overall condition of the baby in terms of the amount of respiratory support, the hemodynamic stability that you have, and if you have other conditions that may actually make the situation worse, we also discuss that with the team. So it's
So
not
this
an
means
easy
that it's
decision.
always a dynamic decision. I mean,
Definitely,
you cannot
100%
put rigid
dynamic.
criteria for that.
100% dynamic. We don't have a set day, say, we always operate on third day of life. That
No, I mean beyond this. I mean, inside the field. I mean, you don't have this rigid. I mean,
no, we don't. And I don't think it will be wise to have a rigid decision because every patient is different, every case is, they have different severities, and you have to be able to adjust and be flexible. On when
and
to send the
consequently
patient.
defining how stable is stable enough to undergo surgery.
Again, sometimes you have to make a decision that you're going to send the baby for surgery, although the baby is not stable as you think, because there are some babies that won't get more stable than what you have. So you have to also assess the ability of that baby to get better without the surgery. You get to a point that you say, well, the baby is not stable enough, but I don't think my baby is going to get more stable if I don't operate. And that's a time when you have to say, I know the risk is high or is higher, but I need to send it for surgery. I can't keep treating the baby without closing the defect.
And the parents are involved in the decision as well?
Usually we involve the parents too, and we explain the risk of that.
Right.
I don't know if Yasser want to comment on that, but that's usually what.
Thank you. Thank you very much. But I will just add like more specific points. As Ruben said, that there is no very strict yes or no answer for anything. So it is patient by patient based. And typically there is a key persons, like to be honest, like everyone should be involved with the neonatologist on call. And maybe second opinion from another neonatologist might be considered. The hemodynamics person responsible for that, maintaining the hemodynamics is integral part. The pediatric cardiologist, if there is any other congenital heart anomalies included, and the anesthesiologist plus the pediatric surgeon, plus parents on top of that. So the best situation that usually the anesthesiologist and the pediatric surgeon, and I mean more than anesthesiologist, they would like to get the pulmonary artery pressure at least equal to systemic or subsystemic with the spitter without even support, without nitric oxide, if we are able to do that. And the blood pressure maintained to the normal level without cardiovascular support, if possible, or with a single agent, like non-diaphragmatic low dose. We don't like to send to get the patient to surgery with multiple medications or multiple support for pulmonary hypertension. And day by day, if we are reached to the point that I tell the surgeon or the anesthesiologist, I cannot get rid of the nitric oxide or pulmonary vasodilator, and the pulmonary artery pressure now is almost equal to systemic, and that's the best that I can do. And if you are not operate, you will not get any better. Even the condition will worse. Because wait more time, you need to correct the pathology. That's the only way to get the infant improved. And that's our maximum. And they accept, and usually we have a good outcome with that. The thing that we should not do to send a patient with RV or LV dysfunction or high pulmonary venous pressure or multiple cardiovascular medications, unstable blood pressure. Because during OR, the infant might develop fulminant pulmonary hypertension and may decompensate, or significant compromised systemic circulation, and blood pressure might drop significantly with anesthesia, and might die not only from the correction of surgery because of the complications of anesthesia. So these are the things that we should not consider. RV functions should be good, LV functions as well. There is no significant pulmonary venous hypertension or dilated or LV dysfunction. And at least if we are unable to wean the cardiovascular medication, one agent should be enough, and one specific. I have to understand, as I described, the phenotypes of systemic support. If there's vasodilator physiology, there is norepinephrine. But kind of dopamine, dobutamine, norepinephrine on top of that, and this kind of not physiologic mix, that's just a kind of empiric therapy and get things worse, will not really improve the situation. You need to select one agent specific to the underlying physiology of cardiovascular support, and one agent is okay, that can be managed. Because things might get worse during OR with multiple agents. So I hope that I...
Yeah, it's excellent. I mean, my perception of CDH is basically, I mean, the name is errors. It shouldn't be called CDH only, congenital diaphragmatic hernia, but it should be congenital diaphragmatic hernia and its heart. Because my perception as a pediatric surgeon that it is basically, I mean, or a large component, or a large chunk of the problem in these kids is of cardiac origin, right? And here comes another question for you, for both of you actually. We are frequently encountered by a scenario that the pulmonary hypertension is not controlled as we may think it should be to safer levels. And then our colleagues in the neonatology just start to escalate, starting vasodilators. We don't have nitric oxide, but we have sildenafil, we have milrinone. Once we start the milrinone, you have to pay the price of the systemic hypotension, and here kicks in the norepinephrine, etc. My notion, my perception is once you start to kick in norepinephrine to correct what the milrinone has done, okay, we are doing this on the expense of, yes, we treat, I think that we treat the monitor and treat our worries, but the tissue hypoxia consequent to this vasoconstriction, does it count here or not? And what would you do in such a situation where you have pulmonary hypertension is uncontrollable? That's one. Number two, do you think that it's judicial to use a medication like milrinone without strict echocardiographic monitoring, functional echo? This is another thing. And this would be a call to revise our practice here in Egypt based on functional echo, which is, I think it's a must in these kids. Yeah.
Yeah, this is a very important question. So there's like few things that you made my replies difficult because they are resources. It is based on the resources. So typically to get outcome, you need up to the maximum. You need to expect even the worst case scenario. And the worst case scenario, you may not get things under control even with everything you do, and you need to escalate to ECMO at the end. But typically, when you would have even the basic resources to monitor the tissue oxygenation, to monitor the metabolic status with the arterial blood gases and the continuous arterial monitoring, and to get the level of lactic acids in time. And I'm not talking about advanced monitoring by near-field spectroscopy, but at least to get arterial, not capillary, not venous. Venous is not reliable blood gases. I'm not sure what you are reliable here, capillary or what kind of blood gases.
Mostly it's venous.
Okay. No, venous is not acceptable. You accept? Not acceptable. Venous, if you get the venous, you get it from where? From the arm? You are get actually just the arm perfusion reflection. You are not getting anything from the body. So that's a vein specific for this arm. So you're getting the venous return from the arm. I'm just evaluating the venous status of that arm. That's it. The venous is not acceptable. Capillary, if you don't have arterial, but also is not really reliable, helpful in critical situation. You need arterial line for two things. And I think arterial, umbilical arterial line is not that difficult, but you need the transducer, you need the monitor to be calibrated, and you need a bedside nurse dedicated for that. You cannot accept like less than 1 or 2 nurses dedicated to the patients and to take care of the line. You get the blood pressure monitored continuously, so any drift with the blood pressure below the acceptable values, you will detect that in time, and you need very serial, frequent arterial blood gases to reflect the tissue perfusion. If you don't have near-field spectroscopy, at least you will get the acid-base status and the lactic acid level. Without these basics, it might be really difficult to manage. Without these basics for monitoring, it's really difficult. And once you have these resources, you need also to have the dedicated team. And the dedicated team, there's 2 key persons. Besides the neonatologist, the other person from NICU, a trained person in hemodynamics. Beside the pediatric cardiologist, you need the person who can assess the blood pressure, echocardiography in details about the functions, and describe the medication needed based on the underlying physiology. Milrinone is not the medication that we use as a pulmonary vasodilator. No, it is used for RV dysfunction. to improve or LV dysfunction, but not as a pulmonary vasodilator, because if you use it for that, you need a higher dose, and typically the blood pressure will drop. And you need to add more medication and so on.
Well, this is a common scenario that we have, but we have to be, I mean, realistic. Our patient populations, I think, is much different from yours. Mostly they are not diagnosed antenatally and they come very late, mismanipulated, etc. So probably most, if not all, our patients run in the high risk category and not the, the low or mid risk category. And this poses a lot of logistic even problems in dealing with the kids. Anyway, thank you very much for
if I were to pick the 4 reasons why survival has increased over the last 20 years, I would say first, better prenatal diagnosis. Second, better way of ventilate these infants. Third, better hemodynamic diagnosis and control. And 4, delay surgical repair. Those are the 4 elements that have basically shown to improve outcome over the last 25 years.
We can complete the program.